And then you can see the other things we looked at here. We looked at the current weight. We are doing well with weights on the chart. However, we're not doing so great with the dosing weight. So the dosing weight wasn't actually listed on, it was only 58% compliance with that. And then allergies entered before the first medication, 61%. So we still are entering orders without having allergies on the chart. So that's pretty much the summary of the med audit.
Okay, I believe there are some P&T committee members in group 1 and 2. I understand you have some comments about this and some possible recommendations. So representatives from group 1 and 2, please speak up.
This is group 2 in Athens. MedRec, we recommended that pharmacy take over that process, possibly an intern to do the MedRec, and then have a pharmacist sign a date and have the pharmacist input that into a EMR. And for the allergy matching that in the computer, we recommend like a barcode technology, possibly phasing that in. And that way those barcodes would be scanned and that would be an automatic submission into the computer.
Okay, now tell me again about the barcode it's doing.
It was saying that the chart stickers didn't match allergy computers.
Okay. All right, so you were group 1? All right, group 1, do you have anything to add to that?
For allergy list, we said that we should provide nursing education and importance of correct documentation of allergies, and we would have them come up with a routine workup of initial patient workup, so it'll include medication allergies and and the dosing weights entered before we start on any therapy.
Okay. Okay, for group 1 and 2, there are a couple of recommendations here. One is to, deal with medication reconciliation where students possibly could assist the pharmacy department to have the pharmacy department responsible for med reconciliation. A couple of recommendations on medication allergies. One deals with scanning the barcode, so make sure it matches what's on the chart. The other one is to make it part of the nursing history. Is that correct?
The initial workup process, we would include it in the routine.
Okay, we'll make that part of the initial workup as well. And that would also include the dosing weight. So about 3 recommendations there. Anything else?
I have just a question regarding the use of the interns and the barcode technology. Is there any plan on how those resources would be acquired?
I believe that was Group 2's recommendation. Anybody from Group 2 want to comment?
For an intern, we could use our relationships that we have with College of Pharmacies around the area and obtain, have an intern rotation, and they could help phase in that program in. As far as the barcode, there seems to be already chart stickers that are used, so we could contact that company about the possibility of printing a barcode on those stickers.
Okay. I think for reality purposes, that one about interns, why don't we make the recommendation that pharmacy explore that as a possibility to solve med reconciliation. So we can see if the resources are there with the college. Is that acceptable to the group? I hear someone talking, but I can't hear. Oh, they're in the hallway. They're not P&T members. Tell them that. Be quiet. Okay. I think we're ready to vote on our recommendations. If you'll go to your vote, you can vote yes or no to approve these recommendations. Vote now, please. We'll see how well class is being attended today, too. The bottom right on response is a little blurry to me, Diane, so...
There's just up to 86, so...
Okay, when you think it's got the critical mass, you go ahead and reveal the results.
We're up to 90, I think I'll go ahead and stop it.
Okay, so it looks like the committee is ready to approve those recommendations. Thank you very much. Group 1 and 2. Dr. Kane is here with us today, who's going to present some information on the request to add IV acetaminophen to our formulary. Dr. Kane.
Hi, so the first drug we're going over is IV acetaminophen. Brand name is Zofirma, and currently it's indicated for management of mild to moderate pain as well as moderate to severe pain in conjunction to the standard opioid analgesic. And lastly, it can be used to reduce fever as well. As far as the mechanism of action, it isn't well documented. However, it is thought that the antipyretic effects are due to the inhibition of heat regulation in the hypothalamus, and the analgesic effects due to upregulation of inhibitory heat-sensing pain pathways in the CNS. Some key points as far as pharmacokinetics, heat concentrations are observed at the end of a 15-minute infusion, meaning there is a relatively fast onset with IV acetaminophen, with analgesic effects seen as fast as 1 to 10 minutes and 30 minutes for antipyretic effects. And this is most likely due to the higher peaks that are reached with IV formulation. Studies have seen that after about 4 to 6 hours, concentrations are relatively the same as the oral options. Acetaminophen is metabolized in the liver via glucuronidation and sulfation. However, at higher doses, it is metabolized by CYP2E1. When glutathione stores are depleted, it can result in an accumulation of toxic metabolites and causing hepatotoxicity. Acetaminophen is generally well tolerated. However, it does share the same adverse effect profile as the oral formulation. As far as drug interactions, it's mostly seen with concomitant therapy with other hepatotoxic medications, as well as changing levels in other drugs such as lamotrigine, probenecid, or warfarin.
Okay, I come to understand that there are some P&T committee members who want to talk about some specifics about clinical efficacy. Do you feel the data is strong enough for any of these indications for IV acetaminophen to be on a formulary? And is there any newer literature that you can contribute to support or refute the indications listed, or an indication that's not currently listed? So I'll turn to members from group 18, 19, and 23 for a response. And please speak up loudly so I can hear you.
This is group 19 in Augusta. We looked at the clinical efficacy for the pain, specifically cancer pain in the emergency department, sickle cell anemia, and obstetric patients. So the clinical efficacy for cancer pain, IV acetaminophen did not improve the pain score. So within the 24 hours that they studied, there wasn't a statistically significant improvement within the pain scores they were observing. And then for the emergency department, it was shown to be non-superior to the available options. So opioids showed a greater decrease in the pain, but then when they evaluated adverse drug reactions, there wasn't a statistical significance. One study compared fentanyl to IV acetaminophen, and in that study, they excluded all patients requiring rescue medication. So I think that leads to preference towards the fentanyl because we can't see if that IV acetaminophen required rescue medications in those patients. And then there was also no difference between the oral IV acetaminophen versus the oral acetaminophen versus the IV acetaminophen, which has a huge financial difference, or a huge cost difference between the two. And then also there was another study that showed IV acetaminophen plus oral oxycodone versus IV morphine. There was no difference between the groups, but we were a little confused on why they studied it that way, because if the person can take oral oxycodone, they should have probably also been on oral acetaminophen. And in that study, they showed that there was more nausea and itching with the group with the IV acetaminophen. Then our last two were sickle cell anemia and obstetric patients, and both of those showed no evidence. There's actually no literature in the obstetric patients at all. So we all agreed that we would not support the use of IV acetaminophen being put on the formulary.
Okay, interesting information. Group 18, anything to add?
Group 23 found a new article from January of this year. They compared the use of IV acetaminophen with an opioid to just opioids for vaso-occlusive crisis in pediatric patients. And it showed that when it was combined with the opioids, IV acetaminophen seemed to be effective compared to opioids alone, and it also reduced the use of opioids.
Very interesting. How about group 18? Anything to contribute?
We agreed with a lot of what Brielle said, including some of the kind of questionable data about why a patient would need IV acetaminophen if they could take oral oxycodone. And we also found that in 2018 at least, the IV formation cost about $40 for a 1,000 milligram dose, whereas that would be pennies in a tablet form. So we also do not really support the use of IV acetaminophen for any of these medications.
Okay, thank you very much. I understand that there are some members, PT members from group 3, 4, 24, and 25 who are supportive of acetaminophen being added to the formulary. Would these groups each give me a reason why we should be voting yes for this product?
This is Group 3 in Athens. We feel that IV APAP presents several advantages over the currently available formulary options for IV analgesics. These advantages are in relation to safety and pharmacokinetics, which are 2 of the 5 criteria for a drug to be recommended for addition to the formulary. Safety. The adverse event profile of IV APAP is similar to placebo. This represents an advantage over other IV analgesics to which APAP is non-inferior in efficacy. According to Craig, 2012, IV APAP is as effective as low-dose IV morphine for acute traumatic limb pain, and APAP is safer than morphine in many aspects, including renal effects and risk of accumulation, risk of respiratory depression, and sedation that accompanies opioids, and this would reduce addiction potential associated with opioids. According to Terpur 2014, IV APAP is equally efficacious to dexketoprofen for acute migraine attacks. NSAIDs present several safety concerns such as possible AKI, peptic ulcers, and GI bleeds that are not present with APAP. According to Kuchek et al. 2013, IV APAP is equally efficacious to IV fentanyl for mild to moderate pain in ICU patients. APAP presents a safety and security advantage over fentanyl because of the potential adverse effects of fentanyl, the potential for diversion, the potential of addiction, and risk of dosing errors due to fentanyl being in micrograms compared to the majority of other analgesics being dosed in milligrams. Pharmacokinetic advantage. IV APAP is pharmacokinetically advantageous because peak plasma concentrations are attained at the end of infusion time. Therefore, it would be easy to discontinue or change analgesic medicines as needed without concern for continued on or off target effects of APAP or drug-drug interactions with any agents that might subsequently be initiated. Another pharmacokinetic advantage of APAP is that APAP is primarily metabolized by the liver. This makes it a good analgesic option for patients with renal dysfunction. There would be no chance of accumulation of APAP or risk of prolonged sedation and respiratory depression when patients use APAP compared to opioid analgesics eliminated by the kidney like morphine. In conclusion, the ability to administer an exceptionally safe, relatively short-acting analgesic via the IV route represents a convenient option for patients who are NPO and in mild to moderate pain.
Thank you very much. Anything to add from group 4, 24, 25 to that very complete presentation?
We believe that was pretty thorough, and we agree with all of the recommendations.
Okay, what group were you?
This is group
24?
25 agrees.
25 also agrees with buying an apple.
All right, group 4.
Group 4 agrees as well.
Very good. All right. I believe there's some opposition to this drug being added to the formulary from PT members in group 5, 6, and 21. So identify your group and please let me know why you think this drug should not be added to the formulary.
This is group 6. So we compared IV acetaminophen to oral acetaminophen instead of to IV opioids. So safety-wise, you could like the patient could have oral acetaminophen and IV acetaminophen on their profile, which is like confusing and could increase the hepatotoxicity potential if both were given at the same time. The IV acetaminophen has more like sources of error than the oral because it's like you could confuse milligrams and milliliters. There's like weight-based dosing with it. If it's in an infusion pump, you have to know how to program that. And I guess infusion bottles of ropivacaine and IV acetaminophen look similar. And there have been some like reports of mix-ups, which is bad. And also any IV medication poses some risk of infection, phlebitis, and irritation at the site of injection. And there are like a bunch of other forms of acetaminophen available. We have like oral tablets, oral suspension, and the rectal suppository, so we don't think that IV acetaminophen is necessary.
All right, thank you very much. 5 of 21, do you have anything to add to that?
On top of what that group just said, we don't believe that the increase in cost is worth the IV version of acetaminophen.
Okay, what was your group number?
We are 21.
Okay, just make sure everybody gets a chance to contribute. I'll do group 5, ready to respond?
Group agrees with group 6 and 21. Oral acetaminophen is therapeutically equivalent to IV acetaminophen, but significantly less expensive. And suppositories exist if the patient needs to take acetaminophen through a non-PO route. So there doesn't seem to be any point to adding IV acetaminophen.
Okay, thank you very much for the pros and cons of that. We're now ready to vote. And please give us your opinion. We do have an option here to add the formulary guidelines for use, so there is a little wiggle room here if you want to go that route.
We're up to 103 people. All right, we're going to stop it.
Okay, we will not be adding IV acetaminophen to the formulary, and if more data comes out, we can look at possibly adding it with some guidelines. Thank you very much for your vote. Dr. Kang, we're back up with a discussion of dabigatran.
Okay, so the second drug is dabigatran, brand name is Pradaxa. It's currently approved in the reduction of risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. It's also indicated for VTE prophylaxis for venous thromboembolism and treatment of VTE in patients who have already been treated with IV anticoagulant for 5 to 10 days. And the newer indication is for prophylaxis of VTE in patients who have had a hip replacement surgery as an alternative to low molecular weight heparin. As far as mechanism of action, it is a pro-drug and it undergoes hydrolysis and pyranidation into the active metabolite where it serves as a reversible and selective direct thrombin inhibitor. Some key points of kinetics is that it is rapidly absorbed and it reaches peak levels in 1 to 4 hours. The oral bioavailability is increased by 75% when pellets are taken without the capsule shell, so patients should be counseled to take the drug whole and not broken chew or open before administration. It is primarily renally excreted and the drug plasma concentration and effects are increased in patients with renal dysfunction. As far as the side effect profiles, the main side effects are gastrointestinal with up to 25 to 35%, and this is most likely due to the pellets contain tartaric acid. The second is increased risk of bleeding. There are several warnings associated with dabigatran, and one of them being that it's contraindicated in patients with mechanical prosthetic heart valves. And this was due to the REALIGN trial where patients on dabigatran were significantly more, were experiencing more thromboembolic events and major bleeding compared to the group receiving warfarin. And the with all indications, it's dabigatran is given 150 milligrams twice a day, except in patients with hip replacement surgery, where they are given 110 milligrams on the first day, followed by 220 milligrams daily for the rest of the time. That's it.
All right, just to let you know, the role of Dr. Kang is being played by Pearl Kang, with your Palm Beach students. Excellent job, Pearl, we appreciate it. Okay, group 7, 8, 9, and 22, I believe you have some information about adding this drug to the formulary, and if you want to kind of pay attention to the 5 criteria, that might be good. Those 5 criteria are highly likely to appear on the exam, by the way. So go ahead, let me know what you think should be added to the formulary. And identify your group as you talk, I can mark you off.
Group 8 thinks that we should add it to the formulary, and based on some information that was gathered from clinical trials, based on the RELY trial, the rate of primary outcomes, which was stroke or systemic embolism, was significantly lower in the dabigatran 150 milligrams twice daily and non-inferior to warfarin in patients with atrial fibrillation. Based on the PETRO trial, it was found that dabigatran is as safe and efficacious as warfarin in the prevention of thromboembolic events in patients with non-valvular atrial fibrillation. The RECOVER trial showed that dabigatran had similar efficacy to warfarin in treatment of acute symptomatic VTE. The BISTRO trial showed that major bleeding events were significantly lower in dabigatran when compared with enoxaparin. And the REMOBILIZE, REMODEL, and RENOVATE trials showed that dabigatran was determined to be as efficacious and safe as enoxaparin. In terms of safety, as stated before, there is a reversal agent, which is also called Praxbind. And the pharmacokinetic advantage for this drug is that it has a rapid onset of action. I found that it had a peak effect in 2 to 3 hours after administration. And in terms of cost, we think it's the most cost-effective DOAC because it comes the cheapest at $417.97, whereas rivaroxaban is $451 and apixaban is $448.
Okay, other groups?
This is group 22 in Albany. So speaking about trials, there's a rating known as lower risk of major bleed. The dabigatran compared to warfarin, as in the RECOVER and RECOVER-2 trials and the REMEDY trial. The dabigatran had less bleeding events and less major bleeding events compared to warfarin. So that's why I wanted to be added to the formulary. As well about the reversal agent, the dabigatran is the only oral anticoagulant with an FDA-approved reversal treatment besides warfarin. So compared to the other DOACs, the dabigatran is the only reversal agent, which could be useful for emergency surgery or life-threatening or uncontrolled bleeding.
Okay, group 7 or 9, any additional information to add?
This is group 9. We also said that with dabigatran, there are fewer DDIs and warfarin and other DOACs since it undergoes hepatic metabolism, and that there are no dietary restrictions with Pradaxon like the vitamin K restrictions with warfarin.
Okay, very good. Group 7?
We agree with all the other groups.
All right, very good. Now, I believe there's some members in group 10, 11, 12, and 20 who have reasons that should not be added to the formulary. Again, focus on those criteria, which once again, I'll remind you, those criteria will be on the exam, so make sure you know them. Okay, contributions, let's hear it. So,
dabigatran is not a new pharmacological class. It's just an additional drug in that category.
Okay, your microphone is breaking up. If you could identify your group and try again.
We said that in terms of safety, there is a higher incidence of major GI bleeding with dabigatran versus warfarin, and that the incidence of death was the same in both groups based on drug is twice daily, so adherence issues. And it has to be kept in the original bottle, tightly closed, and the product must be used within 30 days.
I'm sorry?
It has a reversal agent, but that reversal agent is over $3,400, whereas vitamin K reversal agent for warfarin is only $97.
Okay, what was your group number?
20.
Okay. 10, 11, and 12. Comments, please?
This is group 11. We would also like to add that there is, in the remedy trials, also been, dabigatran has also been shown to have a higher incidence of coronary acute events. Acute coronary events, almost 4 times as much as warfarin.
Okay, group 10, 12.
Yeah, this is group 12. We agree with a lot of that. There seems to be like there could be some more side effects in certain conditions with the dabigatran. And that reversal agent, if we had to add that too, we really need to consider that cost as well.
Okay, very good. How about group 10?
This is group 10. We agree with all the other points. Sorry, I'm trying to. There's also a new factor XA inhibitor on the market that we can consider adding to drugs that we already have on our formulary because we already use apixaban. So if we're worried about oral anticoagulants and their reversal agents, maybe we should consider adding just one instead of changing one drug we have already on the formulary.
All right, very good. Appreciate everyone's contributions. It's time to vote, and as you vote, please remember to look at this drug as it relates to the 5 criteria, which will be on the exam. I think we're ready to vote, Dr. May. And again, you have the option to add to the formula with guidelines for use. All right, looks like we will be adding dabigatran to our formulary, but we will be developing some guidelines that will be an assignment for another day. Thank you very much.
I wanted to say one thing about the dabigatran, looking at the doses, making sure that when we look at the bleeding, it was usually with the lower doses. The 150, actually the GI bleeding has been a real problem nationwide with that drug. A lot of cases of GI bleeding coming into the endoscopy suites from what I understand. So that's just one thing to keep in mind about this.
We'll definitely keep that in mind when we develop our criteria. I do have some information about the override list, Dr. May. Can you share that with us?
Okay, so as you guys all know, the override list is developed by the hospital. This is something that's required by Joint Commission to say what drugs that nurses can actually get out of their automated dispensing machine without the pharmacist actually verifying the order first. So it really has to be a drug that is for an emergency situation. This is our current list, and we just bring it up for review every year just to decide if there's anything we want to add to this list or anything that we feel like was added that was not really a drug that's used in an emergency situation that maybe we need to take off. So we have a couple of recommendations from the members.
All right, I believe group 13 and 14 want to make an argument for something that's not on the override list to be added, and I want you to explain the rationale. So group 13 and 14.
All right. This is group 13. So on the override list, we thought, why not add regular insulin? Because people overdose on calcium channel blockers and beta blockers, and that could be potentially life-threatening. In the study of the use of high-dose insulin infusion and lipid emulsion therapy in concurrent beta blocker and calcium channel blocker overdose, we noticed that beta blockers are among the most commonly prescribed medications, and calcium channel blockers and beta blocker co-ingestion is a life-threatening condition that requires prompt initiation of comprehensive resuscitation. So if they didn't have to get a prescription for it, they could have access to it a lot faster. And right now, there is no prospective randomized trials evaluating the efficacy of reversal therapy, but we do know that calcium channel blocker and beta blocker OD can safely be reversed by giving it. And interestingly, a dose of insulin drip as high as 10 units per kilogram per hour has been successfully used with improvement in hemodynamics. In another study, an overview of hyperinsulinemic euglycemic therapy and calcium channel blockers and beta blocker overdose, there was a case that the success rate ranged from 80 to 100%, and there was one case that reported a female presenting in 2 hours after ingestion of 5,000 milligrams of metoprolol with a blood pressure of 86/61 and a heart rate of 54. Despite improved heart rate after the intervention with atropine, she remained hypotensive after 3 liters of normal saline. She then received an insulin bolus of 1 to 2 units per kilogram IV with boluses of 50% glucose at a rate of 50 to 75 milliliters per hour. And within an hour, both her blood pressure and her heart rate improved. Despite some ongoing unknowns regarding HIET, it appears to be a promising therapy in severe calcium channel blocker and beta blocker overdose. There was another study, acute management of hyperkalemia, where they discovered that IV insulin can decrease serum potassium by about 0.8 millimoles per liter at 1 hour. And the last study that we wanted to talk about was an effective early intensive insulin therapy on high mobility group box 1 protein levels and prognosis of patients with severe trauma. In it showed that early intensive insulin treatment can probably reduce multiple organ dysfunction syndrome and mortality by inhibiting stress, hyperglycemia, and serum HNGB1 levels efficiently. With all of that, all of those studies, we just thought it would be a good idea to add it.
Okay, thank you very much. How about group 14?
This is group 14. So I think that our group decided that we would really like to add Kcentra to the override system, the emergency override system. And we came to this conclusion because, I know here at the hospital that a lot of prescribers might seem to think it's the post-warfarin world or era, but in reality, we have a lot of patients who come in with warfarin, and sometimes we'll even keep them on and administer it here ourselves. However, it's really important because warfarin overdose can lead to massive bleeding. ACC guidelines say that setting of bleeding with hemodynamic compromise, standard resuscitative measures should always be performed promptly. And Kcentra would provide that because it is a much faster, much more efficacious in a limited amount of time when major bleeding events do happen or when major surgery is called for in a very short amount of time than plasma replacement of coagulation factors or just vitamin K by itself. So we took a look at this. We tried to find some other places that were doing this, and actually there's a hospital out in Texas, UT Health, University of Texas, the Health Science Center at Houston, or the McGovern Medical School, whatever you want to refer to it as. They actually have implemented a very similar system since 2005 of having Kcentra. Over there, they have it so that it may be ordered by the emergency department, the trauma surgery department, emergency general surgery, surgical critical care, anesthesiology, neurosurgery, and pulmonary critical care. Attendings only. And I think that's a very fair way to set it up because it's probably a very expensive agent. And we want to make sure that only the qualified personnel will be able to order this and administer it in a timely manner. But at the same time, because it has so much value in the setting, I think that it will be very good. According to a journal article from the Journal of Thrombosis and Thrombolysis, titled The Safety, Efficacy, and Cost for Effective Profiling Complex Concentrate, aka Kcentra, in patients with vector-10 inhibitor-related bleeding. They showed that it was cost-effective and had a lower risk of adverse events like stroke. and a lower risk of thromboembolism overall. The only other thing I would touch on is that if we were to implement this, we would have to train our healthcare providers on the floor how to administer Kcentra, because it must be concurrently administered with vitamin K and must be dosed based on the patient's IR at the time. Other than that, I think that is about all my reasoning for wanting to add Kcentra.
Thank you. Dr. May, can we vote on these individually?
Yes, let's do the insulin first.
Okay. Those who think insulin should be added to the override list, please vote now. Yes or no for insulin. And it looks like, yes, we'll barely win out on that one, so we will add it and probably have a follow-up on its use next year to see how we're doing with it. I'm going to move to the next drug, Kcentra. Please vote now. And after voting, we've got a couple of other issues to come up, and we need people to present fairly quickly so we can get through the agenda. So I appreciate you being quick with this. I know all the groups want to get a chance to contribute. And that one is also apparently yes, so we will add that to the override list and evaluate it after a year to see how its use has been, if it's been successful.
And just to let you guys know that that would not happen really in the hospital with Kcentra, just because it's such a super expensive drug and the criteria are so specific that we would have it available for emergencies, but we would not let the nurses get it without us looking at it first.
Yeah, it might be available on a crash cart rather than the override list. All right, groups 15 and 16 now should quickly make an argument to remove something from the list.
This is group 16. We would like to remove vecuronium 10 milligrams from the overrideable medication list. This is because it can be mistakenly selected in place of a similarly spelled drug like localized or satellite drugs, which would cause undue patient harm resulting in criminal negligence. To corroborate that, the Institute of Safe Medication Practice recommends storing vecuronium in rapid sequence intubation kits with highly visible containers, such as those with bright coloring, and this is because that separate storage can eliminate the possibility of post-diet administration errors. For example, like a speaker once told us, a nurse at Vanderbilt University had typed in VE in the ABC and with the intent of administering 2 milligrams of Versed, but instead administered the vecuronium and the patient died. So, because the countless errors similar to this that have been reported by the Institute of Medication Practice, we would remove the vecuronium from the automated dispensing cabinet and just keep it separate.
Okay, thank you. The other group, please.
That's a great addition, Sumani. So what we want to do is, just read this right here. So during a hypoglycemic emergency, one of the most important things to have available is glucagon. This being said, having 2 options in the machine may cause some hesitation from the nurse as she's rushing to retrieve the medication. We think that there should only be 1 formulation available, so when the word glucose is seen, there's no delay in the selection of the correct medication. We suggest removing glucose tabs versus the gel due to a few reasons. So for the glucose tablets, if somebody's having experiencing symptoms of hypoglycemia, they may have to take 4 to 5 tablets, which is essentially 15 to 20 grams, and the patient may not be able to tolerate oral medications and could possibly choke. While with the glucose gel, it comes in a pouch, and the dose is it's all available in 1 pouch, so it's more convenient for administration, and just a single pouch provides 15 grams of carbs. The gel can also be more useful in patients that cannot take oral tabs currently or have impaired swallowing. And also, after some research, the gel actually has more rapid absorption, according to an article that I read. It's actually a more concentrated formula that requires less medication. And research at the Women and Children's Hospital of Buffalo found that giving the gel to preterm babies with low blood sugar reduced admissions to the NICU for hypoglycemia from 42 to 26%. And you can't really give a baby tablets, so.
Okay, Dr. May, can we vote for these separately or together?
Yes, let's do it separate.
Okay, Becky Ronian, should this be removed from the override list? Vote now, please.
By the way, we have 110 people in class.
And yes, we'll be removing Vecuronium. Now let's move to glucose tablets.
And that, while y'all are voting, go ahead and vote for the glucose tablets. But for the VEG, that's a reasonable recommendation to take it out of the override. It would still be in the AccuDose, but they would have to have, it would be approved by the pharmacist first. Or you could even his code card, and you just have to grade the code card to do it. So there, that would be an option as well.
Whoa. All right, the glucose. I think that vote is so close, we will discuss that further and bring it back to our next P&T committee. In the interest of time, groups 17 and 26, the two groups need to come up with 3 drugs to be removed from the, are most concerned about, that you're most concerned about on the non-formulary list. Please be brief. We have less than 5 minutes before we cut off. And I'd like at least a minute to tell everybody how they did. So groups 17 and 26, quickly. Tell me what drugs you're most concerned about on that non-formulary drug list.
For group 26, the first drug we have was tigecycline. They're using it for susceptible organisms in several different disease states, but it has a black box warning for increased mortality, and there's cheaper alternatives that cover the same things that they're using tigecycline for. The second drug that we had was sodium hyaluronate, which is Euflexa. They're using it for mild to moderate osteoarthritis of the knee, but it's indicated for patients who have failed non-pharmacologic treatment and simple analgesics. So we would say they need to have failed acetaminophen and oral and topical NSAIDs before using this drug, if using it at all. And the third drug was natalizumab. There was a study that found that there are 2 alternative drugs available that are equally effective, rituximab and fingolimod, and they had less side effects and were also cheaper.
Okay, very good. Group 17, what are your concerns?
We also said natalizumab and tigecycline for the same reasons, but then we also had cidofovir on there. The use has increased a lot over the last cycle, and it's for CMV. It has several administration requirements, such as it needs to be given with probenecid, aggressive prior hydration and post-hydration during after the therapy. And it has to be infused over an hour, or you could have severe nephrotoxicity. And it could be a safety issue if these orders are missed while it's being administered. And also there are other cheaper options like ganciclovir and valganciclovir, an IV and oral option that also treat CMV.
Okay, very good. So we have 4 drugs that seem to be concerned of our P&T committee. So let's group these together and vote if these drugs should receive some attention on who's prescribing it, doing a more formal drug usage evaluation on these 4 medications, and bring back to the committee. So if you think that's a priority for us, vote yes. If not, vote no. Or you got
Well, actually, if they can just type in the drug that they're most concerned about, then we can just have those ranked. If everyone would just type in one drug, we can kind of see what our top ones are.
Oh, okay. I didn't know she was going to do it that way.
Can someone go over what all the drugs were again, please?
I'm sorry, say again?
Can someone list the drugs so that we can respond appropriately, please?
Natalizumab, tigecycline, cidofovir, and one other.
What was the other drug from the other 3?
youth Alexa?
So as you guys are voting on this, just to let you know, if you look at the agenda, the very bottom, there were 3 things at the bottom. It was the top 25 cost drugs, average drug direction report, and the non-formulary report. Those are rotating reports, so every 3rd time it comes back up, so it's reported, a couple of times a year. And this is part of that formulary management system where we're following up on things. If we do have a lot of non-formulary drugs that are being used, especially if they're jumping up the list, maybe we need to actually evaluate those. ADRs, are we really looking at the safety of drugs that we're adding to the formulary, and then just the top 25 cost drugs? We probably need to make sure we have guidelines for those.
Quickly show us the results because we're about to be disconnected.
There we go.
All right. Like a lot of people concerned about tetracycline, I am too. We've got in the last 30 seconds, we'll tell you their impressive contributions. This is
Okay, so I think we got cut off, but just to let you guys know, this is very typical of what a P&T committee is like. You have to come prepared, and you have to say things in a way that people can get like the gist of it very quickly. The agenda may be 80 pages long, so you don't want to have a lot. People lose you if you talk too much. So, like, what is the main point? And you've got to make a clear argument. It's kind of like Journal Club. It's the same principle of trying to make your point and what you add. You always want to play devil's advocate because a lot of P&T committees like, yeah, let's add everything. So the pharmacist is usually the person that's the voice of reason about, let's think about these things. We got to make sure that we have guidelines and we have these things put in place. So, it's a very important role, regardless of what you wind up doing. You're probably going to be involved in the formulary management process. If you're the expert in cardiology, you might be the person who has to come to the P&T committee to actually present drugs that are used in your area. So just learning the skill set and really trying to, do the pros and the cons of each thing. What we do, we just basically present the information. These are the pros, these are the cons, and vote, and try to make sure that we're presenting the information in the best way possible. But you guys did a great job, and thank you for all your participation and for listening to people. That's great. So if y'all have any questions, otherwise.